I'm Jonathan Blodgett, honored to be chair of APF. And for those of you who were on this morning, I think you'd agree with me that we had a very, very great morning of presentations from two icons in the field with Dr. Volker and Gerald Berry McCaffrey. And the award Dr. Berry just got was, it pulled everybody's heartstrings. So such a great recipient of the Pillar Award. So with that, I'm honored to do the introduction of Dr. Koob this afternoon. Dr. George Koob has been the director of the National Institute on Alcohol Abuse and Alcoholism since 2014. He is an internationally recognized expert on alcohol and stress and neurobiology of addiction. Dr. Koob's research explores how the brain and body respond to alcohol and why some people who drink become addicted while others do not. He earned his PhD at Johns Hopkins University. And before coming to NIAA, was an award-winning researcher at the Scripps Research Institute and teacher at the University of California, San Diego. We are excited to have Dr. Koob joining us today, sharing his presentation on alcohol use disorder as a coping response, an extremely pertinent topic as we continue to navigate the ongoing pandemic. Welcome, Dr. Koob.
Thank you very much. Visual okay, sound okay? Yep. Okay, so it's a real pleasure to be joining you. I heard both previous talks, and I think they were an excellent introduction to what I would like to talk about, which is alcohol use disorder as a coping response, Hyperkatifeia, which I'll explain later, deaths of despair, and COVID-19. What I'm going to try and cover here in the next few minutes is the scope of the problem, alcohol misuse and deaths of despair, and how we look at this issue. I'm going to touch on the neurocircuitry of alcohol use disorder and hyperkatifeia, which basically is a follow-up of what Nora was talking about. We call it the misery factor associated with addiction. And I'll introduce a new heuristic framework to understand how alcohol misuse alters the brain. Again, something that has evolved over the years and certainly in collaboration with Dr. Volkov. Alcohol and COVID-19 will be the next topic, and what are the research challenges? And then I'd like to end with moving forward in some emerging issues and priorities in alcohol research, maybe anticipating if there's some questions. So let's get started. What is the scope of the problem? Well, we always focus on the opioid epidemic, and rightly so, because it's killing so many people. But I just want to remind you that we always have an alcohol problem, an endemic alcohol problem. And if you look at the number of individuals with an alcohol use disorder in this country, it's around 2 million, but we always have about 14 to 15 million individuals with an alcohol use disorder. And when you go down the list of emergency department visits and deaths, we have a significant contribution to the medical problems in the United States with alcohol. And I often say that alcohol is the addiction that everybody knows about, but nobody wants to talk about. So I'm going to go through a few slides here and describe some of the issues that we see in the Alcohol Institute regarding the pathology that alcohol imparts. So alcohol-related deaths in the United States have doubled from 1999 to 2017. These were highest among men and middle-aged and older adults, but they increased over time in all age groups, except 16 to 20 and 75 and older. And the increase in death rate over time was greater in women than in men, a subject I'm going to come back to multiple times. These statistics align with other recent reports that have highlighted changing trends in drinking patterns and increased consequences of alcohol in women and the aging population. So in 2015, Ann Case and Agnes Steaton came out with their seminal studies on the increased mortality in the United States. They focused at that time on white, non-Hispanic age group. We now know, and they called these the deaths of despair. And we now know that these deaths of despair contribute to the decreasing life expectancy in the United States since 2014. And they've been observed across many now racial and ethnic groups and age groups. I just point out to you from their work that the three areas that contribute mightily to this increased mortality are poisonings, overdoses, suicides, and chronic liver disease. Alcohol plays about, a role in all of these, contributing to 15 to 20% of all drug overdoses. I want to remind you that alcohol combined with opioids, for example, 2 + 2 = 5 when it comes to respiratory depression, about a quarter of suicides, and half of liver disease deaths in the United States, half. And alcohol's involvement in opioid overdose deaths are charted on this slide. Alcohol co-involvement for all opioid overdose deaths increased non-linearly from 12% in 1999 to almost 15% in 2017. This is pre-pandemic. And alcohol co-involvement persists near about 15% of all opioid overdoses since 2008. And state level rates of binge drinking were significantly correlated with alcohol co-involvement in opioid overdose deaths. And alcohol use is a modifiable risk factor for opioid overdose, as I alluded to earlier. And this graph shows these increases over the past 10 years. And alcohol-associated liver disease deaths and the intensity and the suicide, alcohol or liver disease deaths correlate with the suicide rates at the state level. And you can see here that the suicide rate per 100,000, and you can see the alcohol-associated liver disease deaths per 100,000, and you can see binge intensity per occasion in the past month. So liver disease deaths, binge intensity, and suicides all correlate. And then the burden of alcohol-associated liver disease, as I mentioned, half of liver disease deaths are related to alcohol misuse, but alcohol liver diseases is the most common alcohol-related cause of death and the leading cause of liver transplantation now. And it's moving more and more to younger people. And you can see that in the graph on the right-hand side, where the average yearly increase in mortality due to liver disease is now increasing in young people, and particularly in young women. Again, back to that point. And alcohol liver disease deaths have increased by 40% since 1999. The greatest increase in deaths driven by alcohol-associated cirrhosis is seen in women and young adults, as I've already mentioned. And why am I focusing on liver disease? Well, I think liver disease is a really poignant marker for the pathophysiology that's associated with alcohol misuse. And but it's not the only organ that's affected. There are about 200 diseases that are either caused or exacerbated by alcohol. They range from everything from the lung to neurological issues to bone loss to gastrointestinal disturbances. How many of you who are in practice have seen an individual ending up in the emergency room with a GI bleed because of overdosing on alcohol? And alcohol and cancer now, the National Cancer Institute and our institute have been working together in the last few years. The American Cancer Society estimates that about 41% of men and 39% of women will eventually develop cancer, and about almost 6% of those newly diagnosed cases can be attributed to alcohol. The types of cancer are shown on the right-hand side. Particularly frequent is mouth, throat, larynx, and liver cancer, but also breast cancer. A recent study estimated that 75,000 new cancer cases and about 19,000 cancer deaths per year are attributed to alcohol consumption in America. Surveys reveal a common lack of awareness. A 2017 survey from the American Society for Clinical Oncology found that of 4,000 respondents, fewer than 1/3 recognized that alcohol can cause cancer. And similar results in a 2019 survey, fewer than 50% of respondents recognized cancer risk posed by alcohol. And we have a notice that went out jointly with NCI on alcohol and cancer control. And then I've alluded to this, I want to mention it yet again in another context, and that is we've been observing that male and female drinking patterns are converging. This has been going on now for probably 50 to 60 years. Adolescent and young adults now, alcohol use is decreasing, but faster for males than females. For young adults, alcohol use is increasing, but again, faster for females than males. In young adults, we've actually seen now in some college age populations that for the first time, females are binge drinking more than males. In middle adults, again, same pattern. In older adults, alcohol use is increasing more in females than in male. And so the chart at the bottom just summarizes these gender differences in alcohol use across the lifespan. But what we are seeing is a convergence such that women are now almost caught up with men in their use of alcohol. And what we also know is that studies suggest that women are more likely than men to experience a variety of alcohol-related harms, as I've also already alluded, including everything from hangovers, blackouts, liver disease, brain atrophy, cognitive deficits, cardiomyopathy, faster progression of alcohol use disorder, cancers, and the increases in acute pathology such as emergency department visits, hospitalizations, and death. And women are less likely than men to receive treatment for alcohol use disorder. And in a study that we looked at, a review that we looked at a number of years ago, only about a quarter of structural neuroimaging studies on substance use over 23 years evaluated the sex differences. You know, they measured it in both males and females, but they didn't evaluate the data. So clearly more research is needed to better understand sex differences and alcohol use consequences. And then finally, for my generation, there's rising alcohol use among older adults age 65 and older. You can see the convergence, which is this graph that's shown on the left is similar to what you would see for any of the age groups I showed. 1 in 10 older adults in the US engage in binge drinking. Why is this important? Because it contributes to accelerated aging, reductions in brain volume, impaired cognitive function, learning, memory, and motor function. And we know that individuals in this age group are taking many different medications, many of which, as I already alluded to, interact in a negative way with alcohol. So I hate to be such a downer, but I just wanted to illustrate for you the scope of the problem. Now I want to switch to the neurocircuitry of alcohol use disorder and the knowledge that we're gaining that I hope will address these issues. So, you know, I define addiction as everybody else, chronically relapsing disorder that is characterized by a compulsion to seek and take drug or stimulus, loss in control and limited intake. But there's a Koob add-on that I've added on now for many, many years, probably over 25 years. And that's the emergence of a negative emotional state, dysphoria, anxiety, irritability, when access to the drug or stimulus is prevented. And I define that here as the negative emotional side of addiction. I'm also going to define that in a few minutes as hyperkatifeia, and I will explain. Nora very accurately described the 3-stage model, the 3-domain model, and the circuits that are involved. And I am not going to dwell on this, but just to remind you, there are 3 stages: the binge intoxication stage, the withdrawal negative affect stage, the preoccupation anticipation stage. They code for different domains of dysfunction: binge intoxication, incentive salience, and pathological habits. Withdrawal negative affect stage, reward deficits and stress surfeit. And as Nora said, the preoccupation anticipation or craving stage, executive function deficits. I want though you all to realize one really important fact from my theoretical perspective, and that is you can enter this cycle at any one of these stages. We think of entering the cycle in the binge intoxication stage, but what about entering through the withdrawal negative affect stage? Think about tobacco addiction. And what about entering through the preoccupation anticipation stage? Think of individuals comorbid with attention deficit hyperactivity disorder. And you may well ask, well, you guys made this up. You know, it came from imaging studies and some rat studies. Actually, that's not true. This came from a course I taught at the University of California, San Diego, many years ago, a course that I created called Impulse Control Disorders, where I noticed that these three stages were common to all addictions and common to all process addictions. And so one of the things that we've then gone on to do is ask the question whether this can be a framework for improved diagnosis, prevention, and treatment. And again, Dr. Volkow alluded to this, but this was done by Laura Kwaka when she was in our intramural program. And our argument is that maybe these three domains could be categorized by different scales, by different measures, and maybe even different neuropsychological tests, as illustrated in this slide. Maybe we could get a test for incentive salience dysfunction, or negative emotionality dysfunction, or executive function dysfunction. And these three tests that are represented are illustrated on this slide. But at the same time, when we were all discussing these issues, Nora came up with a great idea. Not that she doesn't always come up with great ideas, she's always coming up with great ideas, but we were having a discussion about the protocol for looking at these domains in the clinical center, and Nora pointed out that we already had patients that had passed through the clinical center, and we could validate these domains of addiction cycle by looking at the individuals who already passed through the clinical center. So using measures of addiction, personality, cognition, behavior, and exposure to early life stress, they were collected in 454 patients from 2015 to 2016 at the clinical center at NIH. And using a basically factor analysis in this large, diverse clinical sample, we were able to confirm the relevance of the three neurofunctional domains of alcohol use disorder. And using a mimic approach, an analytical approach, we were able to identify early life stress and sociodemographic predictors, some of the things that other speakers have been talking about. And so, I think we can argue that these three stages and these domains of dysfunction are common to addiction, and they're particularly relevant in alcohol addiction, and they give us a framework with which to develop evidence-based diagnosis, prevention, and treatment of alcohol use disorder in particular. And so the way I think of all this, put it together, is yes, reward has a key role in the etiology of addiction, incentive salience and pathological habits, but also there's relief of negative emotional states and the development of reward deficits, as Nora pointed out, but also I'm going to argue sensitization of stress neurocircuits. And that releases a relief from disruption of those circuits in the brain is another powerful motivator for drug seeking and maintaining drug seeking in addiction. And then you move to the relapse stage of protracted abstinence, and which can be triggered by negative emotional states, but also by cues in the environment. And that can loop you back to this relief stage or the negative emotional stage of the addiction process. So let me just take a minute and drill down a little bit on what I call the negative emotion side of addiction. I always like this slide because it's The Absence Drinker by Pablo Picasso. It hangs in the Hermitage Museum in St. Petersburg. I've seen it twice, once in Paris and once in New York. It's one of my favorite paintings. And basically this lady is drinking drinking absinthe, which contains thujone and alcohol, very high concentrations of alcohol, and thujone is a stimulant. And if you look at all the paintings done at the turn of the 18th to the 19th century involving absinthe, mostly by Impressionists and post-Impressionists, none of them are smiling. And so I just want to, for a moment, focus on the withdrawal negative affect stage and that source of motivation for drug seeking and alcohol in particular. And this is all predicated on a theoretical framework that I think we often forget about, but was championed by Richard Solomon at the University of Pennsylvania. And he argued that when you take a drug, he was arguing for heroin in this particular theoretical paper, but he was arguing that when you take a drug, you have an A process that develops. In other words, you get high, you get intoxicated, and that's shown here. But when the drug wears off, there's a B process, an afterburn, if you will, if you want to call it the hangover with maybe a little bit of too much drinking. You could call it a hangover, if you will, but it was called an opponent process. And his theory, has a lot of big words associated with it, but basically means what goes up hedonically must come down. And what we know is that he further argued that if you become dependent or addicted to a drug or alcohol, you lose this A process, the intoxication, the high, and you gain the B process. And some would argue that the B process actually separates out from, just subtracts out the A process. And so the B process, the hangover, turns into a full-blown withdrawal syndrome and protracted abstinence. So I got tired of using a descriptor for the B process of hypersensitive negative emotional state in my writing. And I knew there was a word called hyperalgesia to represent a hypersensitive pain state associated with trauma, but also with opioid withdrawal. So we coined the word hyperkatifeia. It's defined as an increased intensity of negative emotional motivational symptoms and signs observed during withdrawal from drugs and alcohol. It's derived from the Greek word katifeia for dejection, sadness, or negative emotional state. It refers to the increases in emotional distress and emotional pain experienced by individuals with addiction during abstinence. And it's hypothesized to represent elements such as dysphoria, irritability, alexithymia, simply symptoms often described as ill at ease or not hedonically normal, symptoms historically difficult to define. So, you know, if you look at the reference there, you'll note that we published this in 2010. It never got cited. But I started to use the term in a talk at NIH and people got really interested. So we've returned to hyperkatifeia to describe this malaise, negative emotional state. I'm not talking about a state equivalent to a major depressive episode, but I'm not talking about tiptoeing through the tulips either. It's somewhere in between when you do BDIs on individuals, particularly in protracted abstinence. And it raises the issue of another source of reinforcement that's often misunderstood, and that's negative reinforcement, which is defined as a process by which removal of an aversive event, the negative emotional state of withdrawal, increases the probability of a response. And you know, Nora talked about the loss of reward function, but there's another piece to the neural circuits associated with the withdrawal negative affect stage associated with hyperkatifeia, and that is a gain in the brain stress systems. And I arbitrarily call these systems that we know mediate fight or flight in normal circumstances, but when an animal or a human being becomes excessively activated in these brain stress systems, such as CRF, dynorphin, norepinephrine, vasopressin, hypocretin, neuroimmune factors, they can drive a great deal of distress. And some of these neurotransmitters that are part of the stress system actually also contribute to the decrease in dopamine and reward neurotransmission that we observe in hyperkatifeia and in withdrawal. So I want to, you say, well, why did I go into all this part of the addiction cycle? Well, because I'm persuaded, and our institute is now putting a lot of energy into trying to understand the interaction between hyperkatifeia and prevention and treatment and the etiology of alcohol use disorder. So we had a congressional briefing a couple of years ago now on women and alcohol. Martha Woodruff, who is a former public radio journalist, and she terms herself a late blooming novelist, gave a beautiful talk on her personal experiences. I asked her whether I could have a quote, and this is what she provided. "I grew up professionally focused and personally adrift. There's a long history of depression in my family, and my childhood home was dominated by my mother's mental illness that was not recognized, let alone treated. Sometime in my mid-30s, I started using alcohol to provide relief from the pain of childhood damage and organic depression. Bourbon was the only thing that would make the loop tape of despair in my head pipe down." So I just want to remind you that there's an interface between physical pain and emotional pain. And alcohol is a pretty good pain reliever. Unfortunately, only at doses that practically are at the legal limit, or what we would term at the Institute, the binge limit. And so this slide is just a meta-analysis showing that in a whole herd of studies, there is a significant pain relief when you get up to blood alcohol levels of about 0.08 gram %, which is the legal driving limit. limit. These findings suggest that alcohol is an effective analgesic that delivers clinically relevant reductions in radiance of pain intensity, which could explain alcohol misuse in those with persistent pain. And the doctors I know who are pain docs, and I know quite a few in the San Diego area, all report to me that their patients are increasing their alcohol use to accommodate increased scrutiny of the use of opioid pain medications. And so I think in some sense, alcohol is taking on some of the role that the opioids took on with the same deleterious effects. We also know that there's increased pain sensitivity during alcohol withdrawal. So you end up trying to fix the problem with drinking, which is exacerbating the problem, similar to what we see with chronic administration of opioids. And so in a study of human beings on the left-hand side, you can see that severe alcohol withdrawal compared to mild alcohol withdrawal is associated with increased sensitivity to pain. And if you correlate this increased sensitivity to pain with the Beck Depression Inventory, those people who have more depression are more sensitive to pain. And I just want to point out to you one little piece of a rat study over here on the right, which is a study we did a number of years ago that shows that a CRF antagonist, that is a stress neurotransmitter antagonist, can partially reverse the hyperalgesia associated with alcohol withdrawal. And I might add opioid withdrawal. And so where do these circuits overlap? And I know you're probably not board certified neuroanatomists, but these are the pain pathways, the classic pain pathways in blue, and one that's been called an emotional pain pathway in pink. And you can see there's a convergence, particularly of the pink pathway from the dorsal root ganglia to the parabrachial nucleus to the amygdala. So they overlap with my beloved extended amygdala, and pain is actually the amygdala. And we know now the amygdala is involved, has nociceptive neurons, they respond to pain, but they also, the circuitry in the amygdala particularly responds to the affective component of pain. And so to reiterate, physical pain can cause emotional pain, and emotional pain can cause physical pain. And we think this is the case in alcohol use disorder. And so, others have spoken to this issue in different ways. I'm going to put it in the terms of allostatic loads that contribute to addiction. And so the argument is that the opponent process doesn't disappear when individuals develop addiction, but there's a decrease in their hedonic threshold. And instead of returning to a hedonic homeostasis, return to a state that's called allostasis, which is a change in set point, with a compensated equilibrium, an abnormal set point, and it's inherently unstable rather. And the best I can describe to you about allostasis is think of the weight you gained doing Zooming for a year and a half now, and how easy it was to gain that weight, and then think about how hard it is to get rid of that weight. And that's a change in set point. And my argument is, as Nora's was, that genetic and epigenetic factors, childhood trauma, psychiatric comorbidity, all are weights on this drift of hedonic set point, and also excessive drinking, which contributes independently sometimes of any of these allostatic loads, but the allostatic loads certainly exaggerate that interaction. So what about alcohol and COVID-19? What are the research challenges? Well, there actually were four in the height of the epidemic. One is a biological effect. We know that alcohol misuse is much more highly represented in acute respiratory distress syndrome. I'm not going to dwell on that, but there are disruptions in immune function with alcohol, and they could be exacerbating the response to COVID, to SARS-CoV-2. Likewise, it could go in the other direction. Disinhibition, of course. We know that situations where alcohol is being imbibed indoors with poor ventilation and close quarters contributed to outbreaks of the pandemic, presumably with people masking in indoor locations and controls. A lot of that has disappeared. But the more poignant piece of the alcohol interaction with the COVID-19 pandemic is similar to that for other drugs of abuse, and that is the isolation. The physical distancing can lead to social isolation or loss of social support, which leads to stress. And that's already been covered very well by Dr. Volkoff. But we argue that drinking to cope with stress during the pandemic is at the root of some of the increases in drinking that we've observed during the pandemic. And in addition, as you well know, the treatment and recovery challenges caused by the physical distancing. And they emphasize the need for telehealth and virtual meeting options for individuals seeking treatment or recovery from alcohol use disorder. So, the diagram shows that isolation and stress can lead to alcohol misuse, but alcohol's effects can lead to biological interactions and behavioral interactions that could drive exacerbation of some of the effects of the pandemic. And are people drinking to cope during the COVID-19 pandemic? Well, studies suggest, a myriad of studies now, that some people are drinking more during the pandemic, others are drinking less. And stress is a common factor for those drinking more. And there's a listing here. The survey by the American Psychological Association found that 1 in 4 adults reported drinking more alcohol to cope with stress during the pandemic. Survey of 12,000 physicians reported many experiencing burnout, and again, about a quarter of them drinking alcohol to cope with it. Another survey, 30% almost of respondents reported drinking more, and the odds of increasing were higher for those with symptoms of anxiety and depression. And other studies suggest having psychological well-being impacted negatively by the pandemic is associated with more drinking days and more drinks per occasions. And this is some data of alcohol consumption, just so you can see actual data here. This is a longitudinal study of 790 adults aged 21 and older, and compare with February 2020, average drinks per month increased 36% in April and 39% in November. The increase seems to be persistent. And this goes to drinking beyond 7 drinks per week, which is the dietary guidelines. It also goes to the percentage of people engaged in binge drinking. And many of you know that a binge is 4 for women and 5 for men within about a 2-hour period. Alcohol misuse correlates with poor mental health. It often precedes diagnoses of mental health conditions. It's commonly used in an effort to cope with symptoms. In the end, it makes prognoses worse. And similarly, mental health conditions complicate the treatment for alcohol use disorder. There's very high comorbidity with alcohol use disorder, with anxiety disorders and major depressive episodes, post-traumatic stress disorder. And so this cartoon says, I'm right here in the room and nobody even acknowledges me. There was a great deal of discussion of this earlier in your meeting. Obviously, addiction is rooted in the brain, but understanding why it develops and how to prevent it and treat it requires examining broader context of people's lives. As with many conditions, there are social determinants that influence the likelihood of developing and recovering from alcohol use disorder. These include many things that have already been discussed that range from the social environment to the physical environment to health services. These factors can contribute to health inequities and can also serve as allostatic loads, as I mentioned earlier, on brain systems involved in stress, emotion regulation, increasing the vulnerability to alcohol use disorders. And such stressors can drive alcohol misuse to cope, which in turn exacerbates the initial problems, further fueling alcohol misuse. So I think you see a pattern here and why I focus and have been focusing on this hyperkatifeia component of the addiction process. And so we wrote a paper late last year and basically argued that these allostatic loads on the negative withdrawal negative affect stage can be exacerbated by the isolation and stress related to the COVID-19 pandemic. And, I want to emphasize it's just not the isolation. I mean, it's the economic stress, the fear of getting the virus, to many other factors that are contributing to this. Not the least of which is we were already in this state of deaths of despair in many parts of the country. So finally, I'd like to just take a few minutes, and I know this will cut into the question periods, but I think maybe some of your question will be answered by this last part, because I want to talk about what we are doing at the Institute based on this earlier outline. So we at NIAAA fully support and are committed to the NIH Unite initiative. As many of you know, a coordinated effort to address structural racism and promote racial equity and inclusion at NIH and within the larger biomedical enterprise. We're focusing on three main areas: workplace and culture, workforce, and our research portfolio. I often say that, you know, a rich, diverse research portfolio is going to produce better science and higher impact science, and the data support that. We're have underway already work improving health disparities in alcohol health services. One project is assessing the effectiveness of culturally adapted personalized feedback intervention among Latinx individuals with alcohol misuse and anxiety within community-based health clinics. Another is exploring the impact of various combinations of follow-up engagement after alcohol-related hospitalization and assessing alcohol-related outcomes across racial and ethnic groups, including analysis of social determinants of health. A third study is examining barriers to alcohol use disorder care by surveying Medicaid health plan policies related to delivery and management of alcohol use disorder, alcohol use disorder treatment, and the relationship with access to and outcomes for care for racial, ethnic minorities, women, and rural Americans. We're advancing research on alcohol-associated liver disease. We have an alcohol hepatitis network, which has established a clinical and translational network to streamline the design, initiation, and conduct of clinical trials for alcohol-associated hepatitis. In development, we have a NIAAA core liver resource that we hope will provide fundamental information about alcohol liver disease for healthcare providers. But perhaps even more important for the theme of my talk today, we're shifting the treatment paradigm to a whole person approach. So we're planning on integrating treatment of alcohol liver disease and alcohol-associated liver disease and alcohol use disorder to improve patient outcomes. A recent study of patients recovering from alcohol-associated hepatitis found that participation in alcohol rehabilitation shortly after hospital discharge was associated with improved outcomes, including reduced hospital readmission rates, alcohol relapse, and mortality. Nora already covered this. I'm going to go through very quickly, but we know that you can see from this graph that the brain doesn't fully develop and the connections of the brain doesn't fully develop until about the age of 21 and to 25, particularly important in being the frontal cortex, which is involved in cognitive function, but the connection of the frontal cortex with these brain structures involved in reward and negative emotional states. And we're a participant and a very active participant in the adolescent brain cognitive development study, which we do jointly with, of course, NIDA and a number of other institutes now. And we have our own longitudinal studies specifically addressing alcohol that was underway prior to the ABCD study, provided a framework for the ABCD study, and the results recently from that study include evidence that youth who initiate heavy drinking have accelerated declines in gray matter volume and slower expansion of white matter. I know there were some questions about recovery. We have very little we don't know why people recover. We don't know what resilient factors contribute to recovery. We don't know what things are basically of no help in recovery. So in order to improve consistency across recovery research studies, we engage stakeholders to develop a consensus research definition of recovery. Our proposed definition is now on our website. We're planning on publishing this definition in a small review article. The proposed definition describes recovery as a process through which an individual pursues both remission from alcohol use disorder and cessation of heavy drinking. We've disseminated this definition to the broader research community via a recent public virtual roundtable, and we're using this feedback from these stakeholders to refine the definition and inform the direction of new recovery research opportunities at NIAAA. I want to mention very quickly, the importance of screening and brief intervention, referral to treatment. What this slide basically says is that about 80% of people with an alcohol use disorder saw a clinician in the past year, but and a lot of them were asked one question on their drinking, but among those screened, very little advice information was given, and only 5% were advised about treatment options or other resources. And so importantly, screening for alcohol misuse can help clinicians spot other health-related issues. And so given my introduction of the 200 different disorders that alcohol contributes to, alcohol misuse can be a window, particularly to issues surrounding mental health and other substance use disorders. We've have an ongoing effort, a charge I gave to the Institute a couple of years ago to close the treatment gap and to provide resources for the public and healthcare professionals. We have 2 websites that are already out: Rethinking Drinking, a website and print publication for general audience to help individuals assess their drinking habits and ways to make a change. The NIAAA Treatment Navigator. This is an online resource to help people understand treatment options and locate nearby treatment, including telehealth options. Now includes a portal for healthcare professionals to build or expand their referral list to include providers offering science-backed alcohol use disorder treatments to meet the varied needs of their patients. There are 2 locators on here, the SAMHSA locator and the Psychology Today locator. You can type in your zip code and actually find a provider. And coming soon is what we're going to call the Healthcare Professionals Core Resource on Alcohol. It's going to be everything you wanted to know as a healthcare professional about alcohol. And this is going to include presentations on primary care, diagnostic criteria, addressing stigma, medication interactions, and many more. And then we're also putting a lot of energy into the role of telehealth in addressing alcohol use disorder in the post-pandemic era. There was a lot of expansion, as many of you know, in telehealth. The evidence suggests telehealth can be effective for addressing alcohol misuse and can reach people who might not otherwise get support. We're supporting a whole variety of different telehealth studies that range from screening and brief intervention to cognitive behavioral therapy to post-traumatic stress disorder and the motivational interviewing. And the treatment navigator can link you to some of the effective options in this regard. And telehealth actually works for alcohol, brief alcohol screening and intervention of college students. A basics program delivered via teleconferencing leads to reduction in alcohol consumption, alcohol-related problems, and creates a strong therapeutic alliance compared to in-person basics. mHealth, text messaging, mobile apps, interactive voice response technology have been found to reduce drinking and increase readiness to change. Remote monitoring, we're still awaiting new wearable biosensors for alcohol, but people use the Scram device, which is rather large, but another device has been made that's the size of a wristwatch. It's still, the algorithms are still being refined to get an actual blood alcohol level, but it can tell whether an individual's been drinking or not drinking. And then, we would put in this category online support groups, which you're all very familiar with. So I think I've covered a lot of ground. I intended to spend about 45 minutes talking with you about some of these things. I'm happy to take questions for the remainder of the time that we have. And I thank you very much for your attention.
Well, thank you very much, Dr. Koob. You covered so much ground. I appreciate how thorough you were and all the information that we can all take from this to help us going forward. I'd like to ask, we do have time for 2 questions, but I'd like to ask you what was asked of some of the panelists earlier today, and that is, what keeps you up at night and what gives you hope going forward?
What keeps me up at night is what a question that a student asked me at a coffee at the Research Society on Alcoholism meeting that we did virtually. He wanted to know what was the biggest challenge I face as director. And I've been director now for almost 8 years. And I would say it's how little Americans know about alcohol. Now, I get pushback on that statement from time to time, but it's extraordinary how little Americans know about alcohol. Americans think that if one drink makes you, more socially active, socially interactive, that 4 are going to be even better. And it's just simply not true. I mean, you know, at some point, alcohol becomes a toxin. And I think that's the biggest challenge. What gives me hope is that I really believe that the heuristic framework I outlined can provide a really strong basis for evidence-based improvements in diagnosis, prevention, and treatment of alcohol use disorder. You know, I share the same optimism that Nora Volkow does, that the science should lead the way, is beginning to lead the way, and can in the future lead the way. And so, you know, we're putting a lot of energy into evidence-based results, and we're putting even more energy in getting those results out to the public. And that's one of the things I've really taken on as a charge in these last 2 or 3 years.
Just to jump in there, Dr. Koob, thank you so much for spending time with us this afternoon and joining us at our conference. We've, as sort of a patient and family advocacy network, are definitely committed to helping you in that push to make sure that we improve how much people know about alcohol and the science and the findings that you have, pushing it out to our network and making this accessible and that feedback loop between science and the community. We're all in on that. All this, you have amazing data that is so important for people to know about, you know, drinking increases, women, the link to cancer, and very much so people are unaware of a lot of this. There's not enough discussion. There's not enough sort of featuring this and making this front and center. So APF is very committed to being a partner to push out to this network that you're meeting here today and beyond, and anytime that we can.
Yeah, thank you.
If I could jump in quickly as well. Dr. Koob, I'm a member of the board of APF and a retired judge, and have been on the bench for over 20 years. And some of the things you've mentioned today really are so true about individuals' lack of understanding of what alcohol abuse is about. But one question I have, and it kind of ties into a number of factors that you presented relating to the adolescent brain. We, you know, as judges, we saw so many young people when we were doing pre-sentence investigations, if you will, when they became adults, we had to make decisions whether or not to incarcerate or not. And when we looked at those pre-sentence investigations, you started seeing onset of use 8, 9, 10 years old with very few interventions. And the question I have, and I remember sending some adolescents to treatment after they had their assessment. So many of them started appearing before the court with trauma and other type of issues. So I'm not sure if the assessments were really looking at the overall adolescent or just the alcohol abuse at that time. They weren't, of course, addicts under DSM-4, DSM-5 at the time, because they just weren't. They weren't old enough, I believe. But in any event, we would refer some of these young people to treatment, and they would get kicked out of treatment because of their behavior. Well, as you know, Dr. Koob, they're adolescents. They're going to act up. And so what would you recommend when I look at the judicial community, as far as judges are concerned, when they're looking at an adolescent with alcohol abuse issues and other co-occurring disorders, and we make a referral to treatment, what do you think the court should be indicating to the treatment providers as far as how they, you know, because we don't want to cross that line. They're the experts, we're not. But when we started getting kids pushed back because they were acting up, it created a big concern for us. So do you have any suggestions on that, Dr. Koob?
Yeah, you raised a really important issue, and I can relate even on a personal level, because I remember a colleague in San Diego who had a son who, you know, got into trouble with drugs and alcohol, and, you know, could not find a treatment facility for his son. And I think the issue, and you've touched a nerve with me, because this is an area I wanted to put some energy into, and I'm not sure that we have as of yet, but I think the short answer is that whatever treatment facility they're sent to should have some facility or capability of tailoring the treatment to an adolescent, because they're clearly different critters. Okay, I raised a son too, so and you know, I think we really need, if we don't have those kind of specialized treatment, we should, and something I should look into. But I really think that if they could, you know, obviously kicking them out of a treatment facility is counterproductive. So you want to have them. And in some of the treatment facilities now, I mean, there's some in Maryland as well that we've been in touch with, are outpatient facilities, but the people actually go late in the day, they have dinner there, but they actually go home at night to their own place, but they get a full, and some of you are well aware of these kind of facilities, but something like that might be particularly effective for adolescents, where they actually, you know, in that time when they're likely to get in trouble, are actually in their treatment facility, but then they go back to their home where they can be, you know, incorporated into the family unit. I don't know. I'm just thinking off the top of my head.
Well, thank you so much, Dr. Koob, and all the work that you do.
I just wanted to mention what Jessica said about getting you all involved. We've been working for about 2 to 3 years now on this clinician core resource, as I call it. And you know, it's not just for board specialized addiction medicine specialists. You know, it's actually for nurses and pharmacists and nurse practitioners and clinical psychologists and primary care docs in particular. It's really a bit of focus on that. So, you know, we should wrap this up this year, and we'll be happy to share it with you and happy to get your feedback. And it's, you know, everything we're doing right now is a living document. I think it's probably true across NIH at this point. You know, our website can be changed. The words matter, as many of you know. We already wrote that paper and we've changed it throughout our website. The rethinking drinking, we can modify. The treatment navigator, we've already modified. So, you know, we welcome all of you out there, your inputs and suggestions, please.
And we'll also share your resources with all of our conference attendees in our network. Rethinking Drinking and your Navigator are really amazing resources for families and patients and those on the ground. You and your team have done an amazing job building those resources. We reference them and link to them all the time. And as you have more things that we can help to disseminate and help to translate, if we need to take an extra step. We've turned Nora into a cartoon a couple times when we need to really break something down. So I'm feeling a cartoon or two that need to come out so that we can do a much better job of raising up the issue of alcohol use disorder.
Well, thanks a lot. It's great. It's great to hear, you know, that some of these efforts are appreciated. But you know, I got to the Institute and I realized we had a lot of information and it just wasn't getting out to the public, which, you know, and then that loops back to, you know, what you asked me about, you know, what keeps me up at night, and it basically is the issue that sometimes it just gets very frustrating that alcohol gets left in the dust, and you know, it is a legal drug, of course, and it's widely used, and I might add appropriately by most of the population, but for that subset, it can be as devastating as any other drug substance of misuse. I have to be careful here.
We appreciate all of the attention that you've given to language and have definitely taken notice of a lot of change pieces on your website and materials that go out. I think that you are providing really important leadership on making sure that we use person-first language and things that feel helpful to the patient and family community. I just want to mention really quickly one other comment that came in from Kimberly, and you've touched on this, and I think it's part of the title of your talk, Dr. Koob, but so much of American stress and coping mechanisms revolve around alcohol, and that is very apparent after sort of watching some of the responses to the stress of the last 2 years. And Kimberly also mentioned that this is a common sort of issue that you need to focus on in adolescent treatment to help to build new positive coping skills that don't revolve around alcohol or other substances. which is an important part of this. So we'll reach back out to your team and you on anything else from NIAAA that we can share with our network to keep making sure that we give proper time and attention to AUD.
No, there is an argument that when adolescents transition from using alcohol because it involves peer support, in a sense of peer interactions, and the alcohol is a link to those peer interactions, to using the alcohol now to cope with the stress of their adolescent environment, that then is a transition point for more serious problems. And, you know, I think that there's a lot of work still to be done in this regard. So, you know, you know, I think, as Nora pointed out, the social stress in particular, the pandemic has really put a lot of, shone a light on that issue. We've always known that social interactions are very high reward interactions for primates. We're primates. But I think what the pandemic pointed out is how isolation, whether it be from socioeconomic factors or you know, geographical factors, or because you're in a shutdown because of the pandemic, it can have, you know, untoward effects that contribute. So it's really fascinating to see how, if there's a silver lining to the pandemic, it is that we've shown a light on some of these disparities and their interaction with different groups.
And also rebuilding some of that interaction and replacing it with more positive attachment or more positive social engagement, particularly for, you know, adolescents or young adults. That's also so important and can be hard to find in certain communities. So that's really a challenge for a lot of our prevention communities that they're tackling.
And yeah, totally agree.
District Attorney Blodgett, Judge Rancourt, any other questions for Dr. Koob before we wrap up?
No questions for me, just a comment. I really thank him for talking about the issue of alcohol substance use, because sometimes that gets lost in the overall discussion, and it's such a huge part of what we have to do. So thank you again, Doctor.
Well, thanks for having me, everybody. And
Dr. Koob, I would also indicate thanks a lot. I sense some frustration relating to you some days relating to these issues, because it is a tough rock to push over many, many years, as you have done. But please understand that you have made a tremendous difference to so many, and keep up the good work.
okay, well, thanks, everyone. You made my day. So I'll talk to you later.
Thank you.